Hello and welcome to Expert Opinion in ENT. This is Dan Robinson, and today I'm talking to Dr. Sam Dowthwaite, who is a head and neck reconstructive surgeon who works on the Gold Coast Hospital. Sam Dowthwaite did a fellowship in London, Ontario with Professor John New in head neck reconstruction and transoral robotic surgery. Sam Dowthwaite currently works on the Gold Coast Hospital at Gold Coast University Hospital and has an interest in head neck and head neck reconstruction. Thanks for joining us, Sam, and today we're talking about the scapular tip flap. I'd just like to start with asking you, what is the scapular tip flap?
Thanks, Dan. So the scapular tip flap is it's an osseous flap which is based on the angular artery of the thoracodorsal system, the subscapular system. It's generally harvested as an osteomyogenous flap with local muscle flaps attached to it, and it's used extensively in head and neck reconstruction.
And you mentioned muscles. What muscles are commonly attached to it?
So generally, the muscular attachments into the scapular tip that we use as local flap options are the teres major, which attaches into the lateral aspect of the scapular tip, and also the serratus anterior, which attaches into the deep surface of the scapular tip. And variable lengths of those muscles can be harvested with the tip itself.
What length can you expect to attain from those muscles?
It's really quite a random blood supply that's based off the periosteum and local branches of the angular vessels or the serratus anterior vessels if you harvest that as part of the flap. So the lengths of the serratus anterior and the teres major that you can harvest are reasonably short, and defined measurements as to how long those segments can be haven't been measured in the literature with perfusion studies or whatnot.
What vessels and pedicle length is available for the scapular tip flap?
So the tip itself is based on the angular artery, which is variably described in the literature up to, it's probably on average about 7 centimeters from its origin, which is mostly from the thoracodorsal artery, but sometimes it can arise from the serratus anterior as well. But the real advantage is in the dissection of the more proximal portions of the thoracodorsal and the subscapular system, and certainly you can raise lengths of pedicle in excess of 15, 17 centimeters, which is obviously an advantage in head and neck reconstruction.
And what is the approximate flap size which is possible with this flap?
So the length of bone, the real benefit of the scapular tip is that it provides you the opportunity to take a short segment of bone which without waste, and that's really one of the, I suppose, philosophical criticisms of the more widely described fibula free flap is that if to say get a short segment of 4 or 5 centimeters of bone, you're really harvesting a long segment of bone and then wasting a lot of it. And it's the same within the lateral border of the scapula as well. To take a short segment of bone in the lateral scapular border really takes a lot of muscular dissection, and there is that has consequences with regards to morbidity of the patient. So with regards to the scapular tip, you can harvest short segments to say down to 3-4 centimeters up to about 8 to 9 centimeters of bone reliably on just the one vessel, which is the angular artery.
Okay, and what are the steps which you undertake when you go to raise this flap?
So one of the criticisms, or what not criticisms, I suppose, but one of the misgivings of the subscapular system is that the patient position is difficult. Certainly, there are a lot of surgeons who would reposition the patient during the operation. In my practice, I don't. I have the patient in the lateral decubitus position with the modified shoulder and truncal support that places them in about 20 to 30 degrees lateral, so that you can then just roll the table to get them back into the supine position for the ablative surgery, and then you can roll the table to the opposite side that you're working on to turn them into the sort of 30-degree lateral decubitus. And really that allows you the opportunity to prep both your ablative site and the donor site all in the one prep at the start of the operation and not have to re-prep or reposition. And then the steps of the actual procedure itself involve what's called a lazy S incision. It's really it's placed from the axilla, the posterior axilla, over the lateral border of the scapula and down around the tip. The dissections then to the underlying deep thoracolumbar fascia, exposure of the posterior border of the latissimus dorsi muscle, which sometimes need to be partially divided to get access to the tip itself. And then the scapula is distracted, and this is a posterior approach to the angular vessels, which are seen then to be running on the undersurface of the scapular tip, with distracting the latissimus dorsi anteriorly. And then it's a matter of division of the teres major and serratus anterior muscle attachments and following the angular artery up into the thoracodorsal or serratus anterior takeoff, as it may be, and then into the subscapular system itself. The osteotomies are readily performed and easily performed with great visualization of the bone that you're cutting, and freely keeping the pedicle in a safe position away from your saw, and then it requires then for the underlying subscapularis muscles to be divided for the final part of the section.
How do you close this donor site? Is there any specific tips?
So the real key to closure is that you need to reapproximate the serratus anterior muscle to the scapula. That's absolutely vital in maintaining shoulder function in these patients, along with a dissection which protects the long thoracic nerve and thoracodorsal nerve itself. So, but that reapposition of the cut serratus to the scapular muscle, to the scapula itself, with transmuscular and transosseous sutures, is vital to prevent winging of the scapula.
And do you routinely use a drain in these patients?
Yes, so at least one, often two, sort of large bore 19-French Blake's drains, and then the superficial dissection is closed primarily. And with regards to managing them post-operatively, really we get the physiotherapist to reinstate some passive shoulder exercises within the first week, and then they move on to active shoulder rehabilitation, which is a key point in their rehab.
You've touched on the morbidity associated with potentially taking this flap. What is the morbidity that people can expect associated with the scapular tip flap?
So I suppose most of the literature to this point with regards to the subscapular system and donor site morbidity relates to the lateral border, and certainly the amount of muscular dissection that you need to do on a lateral border flap does add to donor site morbidity and reduced range of shoulder function. Certainly that's one of the great advantages of the scapular tip flap, is that your muscular dissection is much less than that with the lateral border, and their shoulder function, at least anecdotally at this point, and we're currently working on studies to compare the tip to the lateral border and to the fibula. Our anecdotal experiences, these patients' donor site morbidity is reduced.
And what recipient sites would you commonly use, or would you recommend as an option to use the scapular tip flap in?
My main experience in using the scapular tip flap is for maxillary mid-face reconstruction, as well as short segment mandible reconstruction. But in any head and neck defect which requires bone stock, whether that be scalp, mid-face, mandible would be our most common sites. Again, the natural geometry of the scapular tip is that it's a fantastic donor site for angle of mandible reconstructions without needing to perform osteotomies. Again, the short length makes it a great option for short body of mandible reconstructions, and in the mid-face it's particularly useful given the point that I made earlier regarding the pedicle length, and that's often a significant issue with regards to mid-face reconstruction, is that if you do have short pedicle, then you're condemning yourself to needing to use vein grafts, and we know that the use of vein grafts does increase your complication rate, so that it can give you the opportunity to avoid those situations.
Sam, thank you very much for your time. As a final parting word, do you have anything else that you'd like to add, perhaps reiterating a point that we've covered or a point that we haven't covered in relation to the scapular tip flap?
I think the main points that I would make with regards to the scapular tip is that it's extremely versatile. It gives you great opportunity to take a short length of bone with minimal morbidity to the patient. It does have some local myogenous paddle options, and it can also be incorporated into a larger chimeric flap where you can take other paddles from the subscapular system, whether that be myogenous or myocutaneous, or indeed the remainder of the lateral border. So it's an extremely versatile flap. It has low donor site morbidity in and of itself, and for patient outcomes and patient rehabilitation, it affords you the opportunity to ambulate these patients early in the postoperative phase, and we know that they, with regards to their donor site morbidity and shoulder function, that they do well.
Well, Sam, I'd like to thank you for participating in this interview. Please stay tuned to the podcast or follow us on Twitter for more updates on expert ENT opinion.